Welcome, everybody, to the live patient experience panel here. We've got some wonderful patient leaders here in the room. And the thing about being a patient leader is when you start on the path of becoming one, you don't set out to become one, and you don't think that you can be one, and you don't really want to be one. You just want to be somebody who feels good. But all of my guests here are people who understand that and have, through them understanding what they need for themselves and their heart, has helped bring people to them and have turned themselves into patient leaders. And that's what we all here to talk about and chop it up with these fine folk today. So we got Jenna Green, we got Samir Ahmed, we got Tamika Zinger, and we got Whitney Carter, and we got all of y'all out here who are joining us and they're in this space with us. Good morning, everybody. So everybody, just introduce yourselves. Like, I'm going to start with Samira. Go for it, Samira. We're going to go. I will call people out randomly, but go ahead, Samira. Tell us who you are, what you do.
Oh, thanks for that lovely introduction, Damien. Super high energy as always. Good afternoon on my side. I am in Boston, so it's the afternoon here. My name is Samira. I am a patient living with neuromyelitis optica, NMO for short. And I am also the founder and executive director of the Samira Foundation, which I founded 7 years ago, 2 months after I got sick with the disease myself. And I'm really excited to be here and hope that I can help shed some light to fellow patients and caregivers in the space. Thank you.
Thank you, Samira. What's going on, Jenna Green? Tell us who y'all, what's going on with you?
I'm so happy to be here. Hi, friends. My name is Jenna Green. I am also in the Boston area. I am a patient with multiple sclerosis, which is, also Damien's got that too, because we're, we all have autoimmune diseases. It's another autoimmune disease, invisible illness, as they say. I was diagnosed in early 2016 and had a lot of privilege to be close to Boston and great doctors and be diagnosed relatively quickly with great health insurance. And then I was forced into step therapy, failed first therapy. They wanted me to try less effective medication and have that fail me and move forward. And that's why I started talking about this, because I wasn't really even sure what was going on with me, if I was going to say anything. But, I'm a marketing strategist by trade, so I understood social media and I didn't have to worry about disclosing to a specific employer. So I knew, again, like I had a lot of privilege, and I love connecting with others in this community, and I'm so glad to be here. So thank you all.
Hi, so my name's Whitney. I'm 24. I'm from Pleasanton, California. I currently live in Berkeley because I go to Cal. This year is my 10-year anniversary of my first autoimmune diagnosis of lupus. I was later diagnosed with a rare neurological autoimmune disease called autoimmune autonomic ganglionopathy, but I'm going to call it AAG for the remainder of the panel because no one can say it and definitely can't spell it correctly. So in AAG, our bodies attack the healthy cells in the autonomic nervous system, which is the parts of your body that you don't control, like blood pressure, heart rate, digestion, urinary tract. So a lot of people with AAG end up with Sjogren's syndrome, which is dry eyes and dry mouth, or they end up on feeding tubes because their GI tract is paralyzed. Or they are in a wheelchair because they pass out whenever they stand up from their blood pressure dropping. I work with many patient organizations with rare diseases and autoimmune diseases, but because AAG is so rare, we don't have any patient organizations, unfortunately, but we have a Facebook group that's around 250 now, so yay. And as I've continued to see a lack of support in the Bay Area specifically, I started a support group for just chronic illnesses in general. That's virtual now because of the pandemic. So.
You as part of your intro raises something super interesting, because we all have found ourselves in the position of like, oh, I'm going to stand up right now, and oh, I passed out because my nerve system doesn't work right anymore. And you sort of have to figure that out over time and through many doctors, or it's a very strange experience. And so as you started to unpack something more wrong with is something is more wrong with me than other things that have previously been wrong with me. Let me figure out what that is. How have you sort of come to not only understand that, but then to go forward to help other people do the same? Samara, maybe?
Sure, that's a great question. So obviously I started the foundation, and that was sort of my way of paying it forward to lend support to other patients in our community. As all of you here know, when you get sick, especially at a young age, I was 25 when I got sick, you just feel so lost, right? And amidst a very complicated diagnosis that many people around you don't know about. So, I started the foundation, but I was also in tandem going through my own personal journey with trying to understand this, trying to wrap my head around NMO. I had never heard of it before. And when they told me, 10 out of a million people get it, there's no cure, they have no idea why it happens, there's no therapies available for it, you're just like, what do I do? And that's sort of when I put my self-advocacy hat on. And I was like, you know what? I have to take matters into my own hands. And I know that you guys can all relate to that, something that I did very early on, as I quickly realized that there was so little known even around me in the medical community, I started to piece together components of my health journey and put it together in sort of a story, so that when I met with a new doctor, a new specialist, I gave them this and I said, listen, here's what has happened so far. It is in chronological order. You have my testing, my imaging, my labs, my discharge notes, every impression from a doctor's visit. Here it is. Read it before I see you, and then we'll talk at my appointment. So all this to say that I think ultimately, when you do get sick, especially with an autoimmune disease or a rare disease, it's so important to sort of step up to the plate and become your own advocate, because as we all know, sometimes we know our diseases and how it manifests more so than the clinicians around us.
It's my grandmother used to say, boy, you better speak up, a closed mouth don't get fed. So if you want to get that wellness, you want to get fed that wellness, you have to speak up. And in order to speak up, you have to know what you're speaking about. Jenna, speak about how you are figuring out your way through, oh, this is wrong, oh, this is really wrong. And let me bring it together and go forward with it. Talk to us about that.
We were able to connect, the four of us prior to this meeting. And as I'm listening to Samira talk and Whitney, there's so much similarities between all of the things that we all go through and that we all struggle with, and the ways that we have, learned to move forward and prepared ourselves to be our own best advocates and connected with others, whether there's 1 million people with your disease or 100. The similarities to me are astounding. And, that's what I love about this disease, about having this disease. That sounds ridiculous. But I love that connection. That's helped me connecting with other people who get it on a level of like, I need to take a nap after I take a shower. Or I'm not gonna wash my hair today because I gotta be on this panel, and I gotta save my energy. And they can't, so they're the people that get that, right? 100%. Like, and that you get the struggle of dealing with an autoimmune situation that affects your whole body and affects everyone differently. There's nothing like that connection for me. I'm a people person, which has been hard virtually, but for me, knowing that I am not alone, and that's kind of why I first started sharing during this journey. I mean, I started sharing because I realized that there needed to be a change in public policy. But then I also quickly realized that there needed to be a change in public perception of people living with chronic illness and autoimmune disease and disability. And so essentially that's why I just don't shut up about it. That's advocacy. I didn't even know that at first. Okay. I didn't even know that at first. I didn't know that was
Look, no,
advocacy.
you speak on that, and that's real, because my efforts in video making has turned into advocacy and has turned into helping people feel less alone. And as an actor, a performer in Hollywood doing the thing, and the importance of me making my own videos as part of my career started to become more apparent. The road started to merge with, like, I got diagnosed with multiple sclerosis. I make a video a week every week. And now I make a video a week about multiple sclerosis because it's the only videos that people on my channel want to watch, by the thousands. And even though I don't want to be the multiple sclerosis guy, like, I'm the multiple sclerosis guy because that's what people want to see and clearly want to hear from me. So like, Whitney, like, as you are, like you say, you gotta just be like, do I have to hook a bag up to my stomach in order to digest food right now? As you sort of find your way through that, how are you building this community through is it outreach? Is it just speaking your speech and letting the folk come around you? Speak on that, please. Oh, she's muted, child.
Yeah, well, I did want to say, Jenna, I showered yesterday because I really relate to that. I was like, I won't be able to do it today. There's no way.
You gotta have your priorities,
shower today,
right?
I mean, passing out in the shower is a very real thing. But community, right? That was the question. I'm trying to remember.
Oh yeah. So okay, we're this is all about community. I think we're all here in this space because we just started speaking, or we're like, yo, I'm going through this thing. I needed what I put together for myself, what my family put together for myself. I'm going to tell other people and not tell other people, at least speak to other people about my experience, because I know that if I am in the world and people can see me, perhaps it could help them. And I make videos to help people feel less alone. That's it.
Yeah, I got you now. I just couldn't remember. Brain fog.
I'm with you. I'll smile with you, Stephanie. Let's go.
Okay, so the community, I mean, with a rare disease, like I said, we don't have a foundation, so it's harder to find people with it. That's when I said Facebook group. I've gotten involved with like general chronic illness groups, rare diseases. I originally went to support groups, but like I said, I was 14 when I was first diagnosed. So
yeah, you're like a sophomore in college, right?
I am now. I was a freshman in high school when I was diagnosed, though. But Jenna shared, oh man, losing it here, that so many of us have like similar symptoms, like throughout over the diseases, which makes it harder to diagnose, but, it makes it that we can relate to each other. And so, getting involved in other support groups, you find people with similar experiences that still provide support. And I actually didn't get involved in advocacy till like after I'd been sick for like 8 years, but I also didn't, I didn't have a choice in kind of sharing what I had, because as a freshman in high school, like everyone knew that like I missed half the school year, like it was obvious. So because it was never private, I just never had the option, and then I just never tried to make it private. So any job I have, they're gonna know.
There's forget the ups, forget the downs. There's the as people who are out in the forefront of their condition, there's some disconnect between like, hi, I'm talking about multiple sclerosis, and like, yo, bro, I have multiple sclerosis, dog. As you work to find the middle of that and continue to show up for people, how do you find the balance between that and showing up for yourself? Take it away, Jenna Green.
Oh, DW with the deep questions.
That's right. I'm out here. I'm profound, swimming the gal. Let's go.
That's why I love you. You know that. That's why I love you. I had to really readdress my priorities in life. And I was 31 when I was diagnosed. So I was young, but I wasn't as young as Whitney. And although I think I was diagnosed quickly after my optic neuritis, but I had it for years. And I was like very much in the hustle culture, doing all the things, working really hard, like had like 15 clients. I'm a marketing consultant by trade, and starting an e-commerce business, like walk dogs, like foster dogs, like all the things, right? No self-care. Self-care was like, I went to yoga, like, did that count, but now I have had to really reprioritize or reevaluate, I guess. Reevaluate is the word. Words are hard, but reevaluate.
They both work.
Yes, sir. Thank you. I had to really reevaluate what I wanted from my life, who I wanted in my life, and what I want my life to look like, and my vision for that. And I had to also accept the fact that it's going to be very different than the life that I had originally envisioned for myself. I'm a big picture, deep kind of person, like on that some levels. Sometimes I'm, really ridiculous, but sometimes I'm a big picture, deep kind of person. So I had to really kind of grieve that old life that I had envisioned and accept that, this life is going to be different, but it can still be amazing.
Still be vibrant.
Yeah.
It's different. It retains its sheen. It just has different sparkles, and like it's not like describing the multiple sclerosis tingling in yourself like glitter, which is cute and fun, and friends of mine do. I'm not putting that spin on it. What I'm saying is that this is another experience that you might not have wanted or expected, or like, but this is the ball that has been thrown your way. We're playing, man. This is the ball's in your court. Now what? And so you're either going to sit on the bench and be like, oh, I hurt, or you're going to like play ball.
I'm going to play ball. I'm going to step up to the plate. I'm going to catch the ball. We can play catch. I'm a softball, baseball girl at heart. So, and the Red Sox are playing tonight. I mean,
watch out. So Tamara, you have started a foundation as your advocacy efforts has gone forward. Has this come out of you just doing your thing and then being like, oh, well, if I sign some papers, I have a company? Or it's like, I'm going to do this in this way and right now. What do I have to do? Let's go. You know what I mean?
Yeah, I mean, I think the whole inception came from a few different things. On a personal note, it came from fear of my own life, not really knowing what was in store for me. The prognosis wasn't looking so good, and everything I had found on the internet 7 years ago about the disease that I now live with was scary. And that didn't sit down well with me. And furthermore, I felt that this community needed awareness so badly. And having been a PR major in college and having done that for work actually in healthcare at the time, I felt that it was almost like kismet, like I was meant to do this, like maybe this is why this happened to me, so I could shed some light on what at the time felt like a very, very dark diagnosis. So it was very personal, but it was also very much for the community. I observed the community online. It was very clear to me that we needed help. And if there was anything that I could do in my power to support this wonderful and very, very strong community, I was up for it. And it's been an incredible 7 years. Never thought it was going to be like this. And every day I'm learning about me, I'm learning about my disease that I continue to live with, I'm learning about the patients and this community, and there's so much to be done, but we've also done so much. So it's kind of like what Jenna was saying earlier, like kind of grateful to have gotten this disease. I think it's brought a lot of light to my life as just Samira outside of the foundation.
Right. It helps give you purpose, and it helps focus you. And people like us emerge to the front because you're a PR person. Jenna was in advertising. I'm an actor, like on the TV for like years. So like, this is when we are met with quite such a challenge, excuse me, an earth-shattering challenge as these health issues, as the people who we are, who we already express ourselves in these ways.
Yeah.
So as we are going to find our way up, we're going to find these ways are going to be part of that. And that's what has us on this panel. And that's that's the message that I aim to get through on the camera here, because again, it's an actor, a PR person, a marketer that's out here with the sheen that from the thing that broke them. And as you figure out your own way through this all, you don't necessarily have to be in PR and marketing and acting to be a patient leader, to be a patient advocate, to be one of these sort of people who are pushing forward, and making not only your life better, but the lives of people around you, no matter how large or small that circle is. And that's something I really wanted to hit home, because it's easy to be like, oh, they do it, I don't do it. But it's like, no, yeah, you do. You be up on this panel too if you just keep doing it. And when we need you out here, girl. What disease you got? It's a very, very, it was important for my brain, my soul, to say, hey, at least make that point, y'all. Again, Damien, and again, as things are not going well, and things are not going well right now, and as you make them go well, what are some ways that you try to help keep yourself going forward? Look, Whitney, you are under 21 years old, okay? You can now walk in and buy a malt beverage if you can, you know what I mean? So you have another set of things on top of these health things. So how do you keep yourself moving forward through these challenges?
I'm actually 24 now, so
yes, you can almost rent a car at the same rate as I can. I love it.
Yeah, well, the reason is because I did drop out of high school because of my health stuff.
Correct.
But yeah, keep going. It's definitely support around me and community, and a lot of that I found in connecting with other people in the chronic illness community, and not feeling alone, because that is so important. And I mean, all of us, I mean, you guys were saying, like, everyone with chronic illness can be on this panel. Like, it's qualifications that we all have. Some people don't feel equipped, but like, all of us just took skills that we already had before we got sick, and we applied them to this. And I think getting involved in advocacy has helped me feel like there's a purpose to going through what I go through, and I'm using it. And that always motivates me to keep fighting. And for other people, I find it actually easier to fight for other people than myself. So.
Speak on it. Appreciate that. Jenna, what say you in that regard?
On how I manage?
Yeah,
everything?
man, like you put the Botox on your feet, child. So just for them to not be filled with shattering pain.
Yeah.
So again, managing the condition that has you speaking on the Autoimmune Association Patient Leader Panel today, and how that manifests in your body in different ways over different periods of time, and still being able to go down to the Senate houses and be like, yeah, this is why you need to make sure that this bill here gets signed off, because if you don't do this, Senator, I can't put the Botox in my feet. So, you know what I'm saying? Because she does that sort of
Personally, I
political
don't
advocacy.
give myself the shot. I would just like to clarify, but I have yet to kick my movement and disorder neurologist in the face. So that is a win. He is a nice guy, you know, and he lets me joke with him about that every time to distract myself because it does not feel great. That is because of my multiple sclerosis. Spasms are, you know, a part of autoimmune disease in general. It's a specific kind of spasm, but you know, it's a thing that I just deal with. And I have learned, I only get the injections quarterly. So I've learned to schedule things accordingly to that. Like 2 weeks before, I am not as pleasant of a person as I am a week after. I know that about myself. And you know, one of the, I hate to say benefits, but one of the side effects of the pandemic is that I was actually able to testify virtually on Tuesday at the State House, which was nice because at least I didn't have to drive. And I did have to sit in this chair for a while, waiting my turn because you didn't know the order, but it worked.
Pardon, Jenna testifies at state houses often as part of her advocacy. And so she's out here on the floor where these laws are getting written and hearing from the people. She's out here for us all, especially with people with multiple sclerosis. I'm sorry.
Well, I volunteer with the MS Society, yes. And if anyone else wants to volunteer, if you have a society that your autoimmune association works with, go to their website and check out their advocacy section, because you don't have to be speaking at the State House to make a difference. And I think that's the most important point here. Just like Damien was saying, because all of our stories, all of our voices, all of those things matter. Those are critical. You do not have to be at the State House to make an impact. Specifically with the MS Society, they send out an email. You can send a template tweet to your congressperson, to your legislator, if you want to, you know, add something about your own story of how, you know, high prescription drug pricing has affected you. You know, you can. If you don't have the energy to do that, you don't have to. So, you know, whether you're sharing on an in-person basis, or if you're sharing something on Instagram where, you know, or you're creating videos like Damien is, I mean, your voice, your story, it all matters. It makes a difference, guys, like it does. And as much as I want to do it all the time, every day, you know, I've learned that I can't, because then I'm useless to everyone, right? Including myself. And you got to learn that lesson the hard way, I think, a few times after your autoimmune diagnosis. At least I did, to learn that lesson the hard way a couple of times, but maybe sometimes still happens. But you got to take care of yourself first.
Look, I mean, Samara, you've got autoimmune encephalitis, from which I could understand is like MS straight on the brain. It is just not quite MS, but just sort of the body is like, so that has a whole nother set of things to stop you from going forward. How do you keep your ball rolling out here? You know?
Oh, so I actually have neuromyelitis optica, which is very similar to MS. And you're right, it does have a whole lot of unpleasant symptoms. So it can be very challenging at times. I will say that I'm celebrating 3 years of remission next month. So the last 3 years have been, yeah, thank you. They've been overall pretty quiet. So that's good. But that's not to say that I don't have my bad days. You know, Jenna, Whitney, Damien, you guys understand that the spoon theory, we have 7 spoons to use in a day. And so ultimately what I have learned is that over time, I'm still learning, it's 7 years and counting, that I have to really pick and choose what I want to do, who I want to see, how I want to spend my time. It was very hard in my 20s to do that, because you're trying to rage and party and be everywhere all the time, have as many friends as possible, dating and all of that. But now as I'm getting a little bit older, I'm getting better at that. And I am still learning to listen to my body, because as what Jenna said, if I'm not okay, then I'm of no use to anybody else. So as much as I want to do everything for everyone else, it's finding the balance of doing that plus taking care of me so that I can continue to do the work that I do. Daily struggle though. And I'm, like I said, I'm still learning. I'm not great at it. Sometimes I pay the price for it, but learning, that's the ultimate lesson here, that I am still learning.
You know, I think for me, some of it is like, I will be, because I get up early and I aim to go to bed early. And it's like, okay, I'm up now and I'll do these things by this time and this time. And then this time comes and it's like, you are not doing those things right now, my guy. And you have to reconform not only your day, but also your brain, and how you're like, you are not less because you did not hit this mark right here, right now. I know it's a noble, you was trying to do that thing. However, you were not able to, and that is fine. It's not fine that you weren't able to, but it's fine that you weren't able to, and take it from there. And that's been one of the things that has helped me, is I've just really tried to be my most potent, energetic, effective self in this space, whatever space I'm being in, you know. It's funny because I said, and I'm like, no, wait, bro, you're the host. So you have to do something right here. For me, and speak on, everybody kind of is, I would say, Whitney, you caught it at some like adolescence through this. I'm still on the 25 point, but like I know a world with a dial tone in a different way to you, you know what I mean? So how do we, I'm really trying to formulate this question here, because do you see like what you know from your condition, and you know of the history of the condition? Do you feel like, oh, okay, you are now in this current time differently managed to thrive than if you were in another point in time? Like, I know I feel that way, you know what I mean? But some people are like, no, I will always have done these sorts of things in these ways. And yeah, can anybody hop on that bandwagon?
Oh, I'll go for sure. Clearly, my education was definitely shaped around it. It does not look like any of my friends. You know, I had to switch to online school, couldn't drive because of seizures, like all those things. My passions are different. The career I want to have is different. You know, I consider myself an old soul because the people I relate to are people with much more life experiences. You know, it's a little hard to relate to some of the experiences that most high school students go through. So definitely the age of diagnosis definitely shaped who I am now and my future.
Wow, yeah, that's potent. Jake Reeves, give me some on that. Speak on it.
You know, learning to be mindful and listen to my body and accept my body for what it can do and be kind to it when it can't. That has changed my entire life. My whole perspective on life has changed. My passion has changed. My focus in marketing, consulting has changed. I want to help different types of companies. You know, I have a passion project for advocacy and changing public perception, but how I spend my days has changed. And, you know, how I celebrate success, how I look at success has changed. And I think I'm kinder in general. I'm kinder to myself. I'm kinder to others. I have more empathy and understanding. And you know, as much as I don't wish MS on anyone, I'm grateful for those life lessons, and I'm grateful for all that you all do. Like, because that's what keeps me going, is knowing that there are other people out there like me that you know, we're just doing the best that we can every day, and that's enough.
It is. A lot of times I just let things breathe. And concept, that notion of like, it's enough,
It is.
it is something that I think, especially when you're dealing with you not feeling like you've always known yourself to feel, and then progressively more feeling like you've never really felt before, and trying to just reclaim some of your identity and some of the things that make you great and have you want to stay in the game, to keep moving forward, to keep, if not even building community, but for others, but keep going for yourself and see what you can do to move the needle, even if it's only this much. And if it's not today, cool. That sort of resiliency is the shiny bow that's on this giant gift of poo that's at the door, that's called MS, that's called autoimmune encephalitis, that's called, I don't even know what you got, Whitney, but Charlie got a lot of syllables in it and I can't say it right now and it sounds awful. Bottom line, it's all wrapped up in that sort of resilience that puts us in this space right here, right now. I'm unclear with how much time we have left on the panel though, because I want to make sure we get in, we land, we took it off and we landed proper. So that's kind of what I'm in here.
We only have 2 minutes left. I want to say we have 2
Yeah,
minutes.
I'm like, I know it's soon, so
It's
I
2
kind
minutes,
of want to land us.
Yeah.
Bottom line, man, we all have slowly figured out that not a little thing was wrong with us, something really big was wrong with us. And how we've transformed what that means into our way forward really has changed our lives and changed the lives of people around us. We have 2 minutes left up in here. So give me 3 words that you felt in your heart when you woke up today, Sumaira.
Hope, passion, and motivation.
Give it to me, Whitney. What's happening?
I feel the motivation, so I'll switch it to determination, resilience, and optimism.
Woo! And bring me on home clean, Jay Green. Let's go.
Number 1 was love, gratitude, and vitality.
I would certainly echo hope and gratitude, and one more time, determination. It's echoing a lot of what y'all have said, because we all have to have some of what you said in our hearts at some point of the day if we are going to move forward with autoimmune conditions. And that's why things like this are important. Things like the Autoimmune Association are important. Things like my channel, things like your foundation are important, because it's people showing up for other people who could feel like them, and you know that you don't feel so good. So thank you for joining us, and thank you for sharing this space with us all. Whitney, Sumaira, and Jen. Thank you. And thank you to the Autoimmune Association for bringing us all in this space and holding space for people with health conditions. Thank you.
My name is Sarah Loud, and I am the CEO of Accelerated Cure Project. We're a nonprofit that's focused on accelerating research in MS. And I'm so excited to be here with you today to be part of this panel. And our panelists also include Dr. Amit Bar-Or from the University of Pennsylvania and Tamanika Zinger from the Sumaira Foundation. And what we're going to be talking about today is clinical trials. What are they? Why are they important? what's going on in research today. And we're going to hear from Tamanika about her experiences of participating in clinical trials and the importance of research. So let's get started. So first of all, what are clinical trials and why are they important? Well, any medication you've ever taken, surgical intervention, and even some behavioral modifications, those are a result of clinical trials. Clinical trials are research studies that involve human beings. And what their primary purpose is to evaluate for safety and efficacy the way a new drug, a diet, or a medical device will perform. They can be used to establish whether a new treatment is better than a standard treatment, and they can also be used in other ways that advance research and an understanding of diseases. They can be used to test ways to find and diagnose a disease earlier, to prevent it altogether, or to better live with a chronic condition such as MS or neuromyelitis optica. Clinical trials are just one kind of clinical research. There are also observational studies where data is collected not exactly in the same way as a clinical trial. So when we're talking about clinical trials, so what do they actually look like? What does that mean? Well, after a research team gets through the preclinical phase where they've evaluated their treatment or modification or intervention in a lab setting, they're ready to move into testing that drug in humans. And so with approval to do that, they start off with a phase 1 study, which is a small study of just tens of people. And what they're looking for in a phase 1 study is the safety of the treatment. They're looking to better understand the dosing, and then some evaluation of the side effects. Although with a study that small, there might not be things that are readily apparent. Once they're successful with a phase 1 study, they move on to phase 2. So you can see that there are more people involved. And still the focus is really around safety and efficacy of the treatment. And now at this point, we're start thinking even more about the side effects. A successful phase 2 moves us into phase 3. Phase 3 is in the thousands of participants generally. And really at this point, we're looking at efficacy and we're looking at side effects, and also perhaps comparison to other more standard of care treatments. Once a drug has finalized phase 3, they submit their data to the FDA for approval. And the FDA pores over reams and reams of data and information that's been generated in these phases in order to confirm the safety and effectiveness of a treatment. And finally, if a drug is approved, there's often a phase 4 where thousands of participants may be evaluated. And the purpose of a phase 4 post-approval is to better understand side effects that might not show up for a longer term, or that might be so rare that it takes thousands of people in order to see them. There are some myths out there about clinical trials and some misinformation. So I pulled out a bunch of them, and I thought that we could spend a little bit of time busting them. So there's a concern that participants in clinical trials are treated like guinea pigs. There have been historically trials that have treated their participants in inappropriate ways. But I'm happy to tell you that there are now many safeguards in place, including ethical review boards and monitoring of studies, so that really a clinical trial participant is never, ever treated like a guinea pig at this point. You are informed before you agree to participate in a clinical trial about the things that will happen, and you're given lots of opportunity to ask questions around that. So you should never go into or agree to participate in a clinical trial if you have any concerns about what will happen to you. But there's just no way at this stage, with the oversight that we have, thank goodness, that a participant is treated like a guinea pig. Clinical trials are dangerous and unmonitored. Well, because clinical trials do often involve a new treatment, there is some risk. But by the time a clinical trial gets to human beings, many of the safety concerns or risks have been evaluated already. And so there's not that greater risk that you might imagine. That said, there are many opportunities during the clinical trial for external monitoring boards, including data safety monitoring, to evaluate what's happening in the trial so that they can identify any issues or risks immediately and address them within the trial. It costs a lot to participate in a clinical trial. There really shouldn't be any costs at all for a participant. There are research and study related activities that should be covered by the clinical trial sponsor. So that's the entity behind the clinical trial that's paying for it. And then there are other types of activities that may be involved with additional care or perhaps just transportation and things like that. And those also should not be brought to bear for the patient or the participant. Those are often covered by your medical insurance and by the sponsor as well. Sometimes there's even modest compensation to participate in a clinical trial, although that should never be viewed as an incentive to do so. Sometimes people are concerned that they'd have to go off all their medications and might even be in that placebo arm that gets the sugar pill. Well, for diseases such as MS and neuromyelitis optica and some of the other ones that we're speaking of today, because there are already existing treatments, it's very unlikely and even unethical to have a treatment clinical trial where you would not be receiving any treatment at all. Mostly at this point, clinical trials for treatments of this type are comparing with standard of care, so existing treatments already. But asking your doctor or your research associate what types of medications you might have to go off of or whether those are barriers to participating is a great question to ask in the informed consent process. Some people are concerned if they say yes to participating, they won't have a chance to change their minds. Definitely not true, and that should be made clear to you at the beginning of the trial and at many points during the trial. You have an opportunity to withdraw if for whatever reason you are no longer interested in participating in the trial or if you have concerns about it. And that should not have a harmful effect on you, on your care, or on your relationship with your doctor. Sometimes people are interested in participating in a trial, but they're not eligible. And so then they have a concern that they're not going to be eligible for any trial in the future. Different trials have different criteria for participation. They're called inclusion and exclusion criteria. So who can be part of the trial and who can't be. But the trials are often very different. And so just because you weren't eligible to participate in a trial in the past doesn't mean that you wouldn't be eligible to participate in the future. And in fact, some trials have very broad inclusion and exclusion criteria so that almost anybody can participate. It's really worth your time to ask and investigate whether or not you might be eligible for a trial. And I will say that there's been a movement towards increasing inclusion from a variety of factors, including age. And so if you were told in the past that you might have been too old to participate, try again. Some folks think that their only source for information is their doctor. And so therefore, if they were eligible for a trial, that they would have heard about it. Well, your doctor and healthcare team can only tell you about the trials that they know about, and they may not know about that many, or maybe at their location, they're not doing that many. So really, it's incumbent upon you and your family and friends to seek out the information about the trials that might be a good fit for you. And I'm going to tell you a little bit about how to do that in the next slide. A really important question that people ask or are concerned about is, if it's not going to benefit me, why bother? Well, some trials do have a benefit for you. You might get access to a treatment that you wouldn't have access to otherwise, and you might get a standard of care or an increased care that you might not have access to otherwise. But also, there's a really strong benefit of knowing that you are contributing to the future of science and discovery, and knowing that you're helping future generations, and even people who are in your family, perhaps, when it comes to a disease that might be genetically linked. And so I would not discount the benefit that sense of well-being that you know you have for being a partner for scientific discovery. So how do you find the research opportunity that's right for you? Well, you can visit clinicaltrials.gov. I will warn you, it can be a little bit tough to navigate, but still you can check it out. There's a lot of information on there, and every clinical trial should be listed. So you can definitely find something on there that might be of interest. You can also use a trial search engine like the one at Antidote. And what that does is it gets to know you by asking you a series of questions. And that way they can help present you with opportunities that are a better fit for you. You can visit the websites of MS, nonprofit, and other disease organizations and get in touch with them to ask what they might know about clinical trials. And as always, you can talk to your doctor and your healthcare team. I really strongly urge you to become this partner in scientific discovery by participating in clinical research and clinical trials. And now I'm going to stop sharing my screen and I'm going to turn it over to Dr. Amit Bar-Or to tell us about what's going on in research today.
Thank you, Sarah. Thanks for that terrific overview of clinical trials and clinical research. And what I've been asked to do is to spend a few minutes going over some of the prospects of research in the field of neuroinflammation, particularly autoimmune conditions that target the nervous system. And of course, you've heard of MS and NMO. There's also MOG-associated disease, MOGAD as it's been called. But it's also interesting to note that as we learn more and more about the normal immune system and about how sometimes it doesn't do everything quite right, that there are a range of other conditions that include some psychiatric conditions and some other medical conditions where the immune system may be targeting elements of oneself, including the nervous system, the central nervous system, or the peripheral nervous system. So maybe before talking about some of the research prospects, we'll take a step back and make the point that, first of all, the last few years have seen, on one hand, terrific progress and some very important translation as we've learned more about mechanisms of autoimmunity and CNS, central nervous system autoimmunity. And this has helped translate a range of therapies to conditions like MS and NMO, but there's still gaps that we as a field need to address. And it's worth pausing for a moment and reminding ourselves that the normal immune system has a number of different jobs. We all like to think of the immune system as protecting us from infections. We know that the immune system is protected, for instance, from development of cancer. We don't always remember that the immune system is also involved in every aspect of repair. So if you injure yourself, the immune system comes in and is importantly contributing to repair of different tissues, including in the central nervous system. And it turns out that it's involved in a range of other aspects of normal tissue development. So the immune system early in life helps shape aspects of different organs, including, as it turns out, the central nervous system, the brain and the spinal cord. And abnormalities in early life immune responses have now been associated with conditions such as schizophrenia, for example. So the scope of how the immune system does its normal job and what happens when it's not quite doing its normal job has been extended to conditions well beyond classical thinking of autoimmunity of the CNS being MS or NMO. And it's important to understand that people who do have autoimmunity, such as individuals with MS, actually have, for the most part, immune systems that work perfectly fine. Of course, there are individuals who have more than one issue, and that's an important observation, but many people will have an autoimmune condition as opposed to multiple. And for the most part, people's immune system is working fine. And one of its major jobs normally is to be able to distinguish what is self and what is non-self. And if it does so perfectly, it will respond to foreign things and get rid of them quickly without that spilling over into injury to self. And the autoimmune conditions emerge when the potential to target self is not properly regulated. And every once in a while, it kind of peaks and causes injury to self. And our therapies and our clinical trials have been designed, when one considers the category of treatments referred to as disease-modifying treatments, or DMTs, to try to target these abnormal peaks or bouts, if you like, of the immune response. And that's relevant to relapses of MS, to relapses of NMO, and to relapses of, for instance, MOGAD, or MOG-associated disease. And in the latter two, in NMO and MOGAD, the conditions are largely related to these relapses and injury that they can cause that then leaves people sometimes with incremental impairments. In multiple sclerosis, it's important to understand that there are two different biologies that contribute to injury to the nervous system. There are, on one hand, these relapses, and on the other hand, this non-relapsing progressive aspect of MS, which we don't really see to the same extent in NMO and MOG-associated disease, and that we think that the relapses in all these three conditions reflect certain immune responses outside of the central nervous system that go into the central nervous system and cause damage. And for those, administering treatments that can target the immune system outside of the central nervous system and prevent these waves of attacks can be very relevant for limiting new relapses and new injury from relapses. But the progressive aspects of MS are now thought to involve a combination of inflammation, still immune responses, but ones that appear to be compartmentalized within the central nervous system. So you can think of some immune cells from the outside coming in and setting up shop in the central nervous system where they can percolate or propagate ongoing injury, and that works together with mechanisms that we refer to as degenerative. So both inflammation and degeneration contributing within the central nervous system compartment to the progressive non-relapsing aspects of multiple sclerosis. And this is why we now understand that even if we very successfully target relapsing MS, if the progressive MS has already started, it's not that easy to change its trajectory. Now, among the advances in recent years, we've become rather good at limiting relapses in many patients and in some individuals entirely, which is very important. So the bar in multiple sclerosis is now set high, as it is in NMO with the 3 newly approved treatments that have emerged just over the last few years to really try to be able to limit, if not entirely stop, the relapses. The gaps that remain, and where a lot of research efforts and ongoing clinical trials are focusing their attention, is on how to target non-relapsing progressive aspects of multiple sclerosis. And there's a whole very exciting field. While 2 treatments now approved for different forms of progressive MS, each of those, to this point, rather modestly change trajectories of progression. And we need to be able to do much better in that regard. And there are families of medications that are now already mid and advanced phase clinical trials that we expect over the next few years will be able to hopefully deliver to the clinic treatments that are more effective at limiting progressive MS. In addition to limiting progressive MS, and then for all these conditions, even when there's no progression, NMO, MOG-associated disease, and so on, a very important unmet need is fixing things that are already injured. So that gets into the realm of repair. And that has been a particularly challenging area in the central nervous system, as you know, across many, many conditions, not just autoimmune conditions, to fix things that are already injured. There are important areas where there have been new mechanisms of both the injury and the repair that are being discovered, and we can talk perhaps in the question and answer about some of those, but that's a particularly important unmet need and a very exciting area. One thing that we hope one day to accomplish, and there's ongoing research, is if you understood enough about what the triggers of conditions like MS and NMO are, is there something that you can do early on to prevent it or catch it super, super early and stop it so as to prevent any impairment over time? And then essentially people continue as though and without really having the active condition. One other unmet need, which is still relevant for relapsing MS, is that many people who may have their relapsing MS controlled reasonably well, if not very well, need to control it by continuously taking immune therapies. And over time, of course, that can contribute to side effects and to risks as well. And one of the unmet goals, or another holy grail, would be to be able to treat with something for a period of time and then be able to stop and no longer continue to treat. And that's really the durable control of MS relapsing activity. And so what I've covered in some ways reflects the importance of advancing our knowledge about these conditions so that we can more rationally target different aspects. This is something that we need to do as part of the clinical trials. And I can tell you where I've spent about 20 years in the field being very passionate about is how can we, as we participate in clinical trials to develop new therapies, take that opportunity to also learn more about the condition itself, whether it's MS or NMO. And that can be achieved if during that clinical trial where people are followed very carefully and we understand how people differ from one another in terms of their responses or lack of responses, if we can measure biologically what is happening across these individuals and relate those measurements that are different in different people to the clinical outcomes and the imaging outcomes that we often incorporate in these trials, we would learn a great deal more, not just about advancing a particular therapy, but also about the condition itself, and then the next generation of treatments that can do an even better job. So I'll wrap up by just saying again that we've made some, I think as a field, we can congratulate ourselves to some extent on very important progress made that has changed lives of people living with these conditions, but we're far from done yet. And there's a great deal of effort ongoing and more to come. And what Sarah had beautifully covered is that aspect where individuals who live with these conditions can participate in clinical trials, and in doing so advance our knowledge and hopefully contribute to new therapies coming out. I'm not an advocate of anybody participating in a clinical trial unless it's a trial that is right for them. It has to be right for them first before it helps knowledge for others. But there are trials of different types, and different trials may be right as one thinks of different people in their different phases of the condition. And I'll wrap up here and really look forward to hearing from Tamanika and then having a chance for some discussion. Thanks a lot.
Thank you.
Hi, I'm Tamanika Zinger, and I'm a patient with neuromyelitis optica spectrum disorder. And I have definitely participated in clinical trials. And for me, in choosing to do that, it was because I wanted to also help with the research and get to be a part of it and to help doctors learn and just help the process go. When I was first diagnosed with NMOSD, there weren't treatments for it that were approved, FDA approved. And so that was something that, slightly frustrating. I mean, at that time when I was diagnosed, the life expectancy was 8 years. I'm past 8 years, yes. So, but, it's one of those things is I feel like as patients, and I agree with Dr. Barrower that you have to do the right one. I'm lucky that my doctor's office, every time I go in and see them, they ask do you want to participate in clinical trials if there is a clinical trial available for you? And I do check yes. But my doctor also says not all of them are going to be available. And that's perfectly fine because that makes sense. If all of them were available, that would be scary. And that would be probably abuse of the system. I don't know. These two are experts, but I do feel as a patient that I want to take the role in participating when given the opportunity, because I feel like that's the only way that we can help on our end to learn. Because I know my neurologist always tells me I'm the expert on my body. I don't always agree. I think he's the expert, but I do live in the body. So I do have to, try it out. And, I had one that I had an allergic reaction. And so it was good for them to have a kind of a reaction to document and things like that. Was the medication working fabulous for me? It was, but the other part of my body said not so much. So, but that's about it. I'm an ambassador for the Smire Foundation, and we have a lot of support groups that a lot of us talk about these things as well. So that's it for me. If anyone has any questions, though, I'm available.
Well, great, because I'm actually going to start with you, Tamanika. So you've actually participated in some trials, that's right?
Correct.
And when your doctor, and it's wonderful that he's able to tell you about the trials that are available, when you're having that conversation, what sort of questions are you asking him to evaluate whether or not it's a good fit for you?
My first question is, am I getting a placebo? And, I know some of them you can't tell. Are you getting the placebo? Are you getting that's not the case. That information is not always available. I think it's like the last one you said, the fourth one where for sure you're getting it. But I always want to know that. I do want to know if they are allowed at that point to tell me what the side effects or known side effects, things like that, what the potential risk is, if they know a potential risk that they can share. I also want to know, my doctor's opinion also. I mean, if they can share it. And I know not all the time they can't. There's certain ones they can, and there's certain ones they can't. And then it's also the question is this medication already out there being used for another disease? Because a lot of times they are out there being used for another disease. A lot of the medications that I get with NMOSD have been used for Hodgkin's lymphoma, other diseases. So it's not new in the sense it's a new medication for NMOSD. And so I do kind of want to know a little bit of a history if I can. And I mean, I love that they don't tell you the name of the medication, because then I would do like every kind of patient probably does and WebMD myself. But I avoid that.
Dr. Google. Right. And so what you just described, that sort of back and forth, is really the informed consent process. So you get information from your doctor, from the study team about what the research is like. and what's likely to happen, what sort of procedures are going to happen. And then you have a chance to ask those additional questions. So it's great that you're an active participant in that, because that's the best way to have informed consent. Dr. Baror, I'm wondering about, from the neurologist perspective, what you see is sort of that conversation when you're sharing information about a trial. Or
yeah, that's a critical conversation. And if you think of what the IRBs, the ethic review boards, want to see, is they want to know that there has been an informed discussion, right? That's where the informed part of informed consent comes in, which means that all the pertinent information that's related to the trial, the agent that's being used, the design of the study, that is a discussion that takes place where both the individual considering participation in the trial and the clinician get a very good understanding of where each other stands, so to speak, with respect to participation. And as Tamanika had already said, people have very different views themselves of what is appropriate or right or wrong for them. Different trials have different risks associated, different potential benefits. And there's a term referred to as equipoise. Equipoise is a very important term for clinical trialists and for IRBs. And basically what it says is that you have to have a balance between whatever the risk is. If there's a high reward, maybe there's rationale for higher risk. If there's low reward, there can't be too much risk. And if there's no equipoise, then that trial should not be done. Or there may be differences in the equipoise for particular individuals in the same clinical trial. So you have to have equipoise overall for a study, but you also have to think of this notion of the balance between the benefit and the risk for that individual in a particular trial. And that's where one really has to have a very clear discussion. And there are different ways now of trying to broach the challenge where the regulatory agencies still like to see a new agent compared to placebo, yet we have approved therapies out there. And there are many contexts in which being on placebo is not appropriate or acceptable. There may nonetheless be situations where a particular individual, once fully informed about options that are out there as part of approved therapies, if this individual says, you know what, I'm aware now of what I could have without being in a trial, but I'm still not interested in what is available, I'm interested in this trial. That may be a context in which a placebo-controlled trial is still equipoise for that individual and appropriate. And there are other ways of being in trials that may start as a placebo-controlled trial, but then there's a crossover where people who are on the placebo will get the original intervention. So then it's not quite the same as never having access to the treatment in question, but it's a delayed access to the treatment. And it's very important to understand, we not infrequently hear people say, oh, I want to be in this trial, but I want to be on the active arm. I don't want to be on the control arm, even if it's an active control, like an existing therapy versus a new therapy. And very important to understand is that if we're doing this trial, it's because we don't yet know all the answers, right? So to want to be in a trial, but to want to be in one arm, if we knew that that was the thing to do, we wouldn't need to do a clinical trial.
That's such an incredible description of the individual's response and responsibility to best assess what's right for them, and to work with their study team and their healthcare provider to really understand where this trial or research fits into their lives and their sort of risk tolerance and things like that. And you touched on it, and I mentioned it as well. You know, there are other forms of clinical research that do not necessarily involve an intervention. And so if there's anyone listening here who's thinking, well, I'm satisfied with my treatment currently, or I'm not interested in going on that kind of trial, but there are plenty of other opportunities as well. There's exercise trials and diet trials. There's purely observational trials where you can contribute to the understanding of the disease, contribute to quality of life measures and things like that. So it's good to know that there's a wide range of options out there for people to participate in. And I also wanted to highlight something you said in your discussion, Dr. Baror, around the contributing to the overall understanding of the disease by participating in research, even if that's not how the research itself is described. And, you know, the careful monitoring and long-term monitoring of people living with these conditions, that incredibly rich information, to be able to collect that as part of a trial and to then better use that to understand the disease. What a wonderful benefit to consider as someone is considering whether or not to participate. So Tamanika, I'm wondering if you've ever been involved in helping to design a trial or giving feedback, because that's a push that's been happening, the patient-centered version of it. And for some, it's hopefully a response to some concerns about recruitment efforts and how we might improve clinical trials for participation for people. I'm just wondering if you've given any feedback to any of your study teams about what worked well for you in the trial and what maybe didn't.
Yes, the last one that I did have like a form, like an exit form to fill out and give feedback and ask quite a bit of questions. And I did actually really like that because I felt that if I had just stopped, finished, they wouldn't get the whole picture of what actually occurred. But by me having to fill out all this information, it gave a more detailed picture of what occurred during this whole process with the medication, with the clinical trial. And I guess I also had like that interest to do that because I had been on a medication one time, and my doctor said I was having a problem with the medication that I was currently on. And the doctor said, well, in the clinical trials, I don't see anything, but call the company and see. And of course, I called the company, and it was funny because he said 5 people in Minnesota may have had that happen in the clinical trial, but nobody's reported it since. And so reporting those things is so good because later on, when patients have something come up, they can say, oh yeah, 5 people did have this experience as well. And it wasn't just an experience. It wasn't anything maybe negative toward it. It was just something they experienced. But it's able to, kind of make it like a full circle, a good communication, a good overview of it. Because if something happens like that to somebody else later when they're using the medication, you say, oh yeah, that did happen to somebody before. And this is what, that's just this. And I don't know, to me, that helps keep it full circle. Did that answer it?
Yeah, no, that was great. I loved hearing about your ability to share your trial experience with the study designers, because I do think that there is this movement towards making sure that studies are designed in such a way that are really accommodating of people's lifestyles. And I'm excited about that trend. As we're talking about this, I'm also wondering about whether or not any study results were given back to you. So there's also a push, which I'm very much in favor of, is making sure that when the time is right, and data can't be given to participants in the middle of a trial necessarily, but when the time is right, that you get some feedback at the end of the trial about what happened, or some sort of closure from that perspective. And so I'm wondering, Tamanika, is that anything that you've experienced in any of the trials that you've been part of? Have you received anything after the fact?
I haven't received anything after the fact, so I'm not sure where those medications lie. Mm-hmm. I mean, I know one was already out there, and I know it was already out actually in stores for usage. Like I could have went to a GNC and picked up that product there, but for what they were testing it for, I don't know if they decided to recommend it as a treatment for it. And so I just knew that it was, they did tell me it's already in stores at GNC if you wanted to, but they just didn't tell me like if they approved it for the design of what they were trying to treat me for. And they didn't tell me the name. Obviously there was no branding on the medication. It was a completely off-brand thing, but I never knew if it worked or if it was useful for other people. So that was kind of a bummer, because it would be nice to know as a patient, is like, and especially if somebody else said to you, hey, I'm having this, and you say, oh, actually I was in a clinical trial for this, I know it's now out there, you should try this. It would be nice to be able to recommend it to somebody if somebody was asking.
Well, I do think that there's more of a push to give appropriate information back to study participants. Dr. Bar-Or, are you seeing that also in your research?
Well, yes, and I think it is an important trend. We embrace it in the sense that when we engage participants first, and this is also something about the something that needs to be incorporated at the level of the informed consent process, is that there are more often than not settings where you need to let the person know that you're not likely to be able to feed back to them directly in a way that's going to be meaningful for their care. Mm-hmm. And the reason for that is that until something is actually formally approved and finished all the clinical trial program, has gone through the FDA and approved, we still don't yet know whether it is safe enough. It may be very effective, but maybe not safe enough, and so on. And the other is that when we get reports from the clinical trials, and by the way, what we've gotten into the habit of doing is keeping track of people, if they wish, who've participated in trials, to be able to share with them the publications that come out of the trials. Now, some of these publications are very detailed and it's more information people want, but we will provide them with that. That's sort of, I think, the minimum that they ought to get back when it has been peer reviewed appropriately and is now sort of published as soon as it is available, with an opportunity to talk about what it showed. But I want to emphasize that one of the things that we as a field have to deal with, clinical trials, as Sarah emphasized, are critical and necessary for us to be able to move towards approval of therapies, but they generally give you an average result. Mm-hmm. This treatment decreased NMOSD activity by 60%. That 60% is made of some people who do better than the average and other people who don't do as well as the average. And one of the things that we need to learn as a field, and this has to do with people being different, is how can we identify the person who's 100% on this drug, but maybe 20% on the other, even though the average may be 60 for both, right? That's a critical piece that I would put in the bucket of, we're still not there yet, but it has to do with this concept of precision medicine, which means being able to actually capture aspects of an individual that will help us understand how he or she fits in to the above average or below average. And what I tell people as we approach diagnosis in the clinic, let's say MS as an example, is I'll mention to them this concept that the clinical trial information that is out there and is critical to understand, and I need to be able to quote, is an average. And you're comparing sort of averages to averages, and it's always a problem comparing across trials that were not, where the medications were not studied head to head. But even more than the difficulty of comparing across trials, we have no way yet of saying, you would be 20% or 80% around this 50% average, right? And so even when you do have results, you have to be careful not to convey information that then gives people an impetus to do something, or they may feel very anxious about not doing something, and it may still be premature.
I think you just raised so many important points. So the notion of individual data return from a clinical trial is not a good idea. It's not where we're heading in the field, but being able to provide the peer-reviewed data in maybe even in a layperson-friendly way, yeah. So that clinical trial participants can understand what the study is determining. And then also your point about the results being an average and not necessarily directly applicable to each individual, but certainly, hopefully, we're on a trend of being able to conduct large-scale research studies that can help us figure out what the right treatment is for the right person. That's the Holy Grail. But speaking of Holy Grails, you mentioned something in your talk that I know would have a lot of people excited to hear more about, which is the mechanisms of repair. So can we talk a little bit about that, share a little bit more information?
Yeah, so on one hand, there are aspects of repair to the central nervous system that challenge us across conditions, from spinal cord injury, traumatic injury like accidents, and all the way through to degenerative conditions like Alzheimer's, for example, and conditions like MS and NMO, where there's been inflammatory injury and damage. The repair that occurs locally is limited, and there are multiple reasons for that. And the challenge of being able to develop effective treatments is that we need to get treatments inside to the central nervous system, as opposed to, for instance, many of the immune therapies that work for the most part outside of the central nervous system. So one challenge is, do you get the drug to where it needs to be? And of course, if you gave huge doses outside, you'll probably get enough in, but then there are likely to be issues with too much for other organs, right? So this delivery to the central nervous system is a challenge for development of medications across multiple conditions that affect the central nervous system. And as you know, the central nervous system has barriers that try to protect it, and that's part of why it's not that easy to get stuff in there. The other then has to do with when there's injury, there's scarring. And when there's scarring, the scar itself can make it more difficult to repair and kind of make those connections that are lost. Mm-hmm. Then you need to get the right cells to be able to do the right things in that environment, not just to get over the scar, but also to be able, for instance, if you're thinking of remyelinating around an axon that is injured, if the axon is so injured that it's no longer there or it's what we call transected, there may not be an opportunity for remyelination, even if you've been able to get the remyelinating cells to the right place to do the right thing at the right time. That, by the way, argues for trying to capture things as early as possible. And if there's one important thing that we've learned, is that being proactive about limiting injury early on, and then having the opportunity to contribute with various therapies that may repair, is much more effective, much more likely to be more effective when done early on rather than later on. We're getting better at preventing damage. We're not quite there in terms of fixing things, but we're likely to be able to fix things more when less damage is done. And whereas in the past, when we have sort of modestly effective therapies that were not quite giving as much benefit for the potential risk, we not infrequently would say, well, let's try with the gentlest thing, and if it doesn't work, we'll escalate. And that escalation approach is perfectly sensible in the sense, and still for many people is the correct approach, because it means that they're likely to be on the least problematic medication for them from a side effect standpoint that may be sufficient. The issue is that if it's not sufficient, more and more damage is done until you get to a medicine that is higher efficacy. And as we've been able to develop higher efficacy therapies that are also well tolerated and generally safe if you use them properly, we're moving towards their introduction earlier and earlier to prevent the damage, or to create a situation where the damage is limited and repair mechanisms and strategies to promote repair are more likely to work.
That's such a great response. And I appreciate, you just gave a great description of the complexities of repair, not only in terms of finding the right treatments for that, but actually getting those treatments to the right place. And then also the hopeful thought that we're doing more in terms of early understanding and early prevention. So we have about probably less than 2 minutes left. So I'm going to turn it over to you all. Dr. Bar-Or, what would you like to say to our listeners on the topic of research and research participation? And then I'll turn it over to Tamanika for the last word.
Well, first, thank you for allowing me to participate. It's really a privilege to be able to speak to a group of individuals who, as I understand, are living with a diverse range of conditions, all related to, in this case, targeting the nervous system. And as I said at the beginning, I think that we are at a very exciting time. We have come a long way, but still have a lot to do to get to where we want to. What will be viewed as a cure for someone will not be viewed as a cure for someone else. If we can identify someone with very early MS and prevent any further injury, that person may consider that a cure. But someone who's been living with MS for 20 years and needs a wheelchair to get around, that's not enough. So we need to do better. And what I will say is that there are a lot of people out there who are passionately committed to trying to figure this out together with you. And I very much like, Sarah, what you said in your presentation. Participation in clinical trials and clinical research of any kind is a partnership. And it's a partnership that needs to be viewed and understood as a win-win, not as sort of the guinea pig analogy that you gave. This is not about trying to use people to further knowledge or to further people's careers or make money for drug companies. It should be about, and there are ways of doing it right. There are also ways of doing it wrong. We now know how to do it right, and that's the way it should be. And I welcome any of you to be part of this joint effort. Thanks again.
Thank you so much. And Tamanika, 15 seconds left. thoughts for our listeners?
Oh, thank you so much for allowing me to be part of this. And, for those out there living with autoimmune diseases, don't give up hope. Stay tuned to the research that's out there and the clinical trials. And for the doctors, stay involved. We're all in this together. And if we are all in this together, it's going to work. Thank you.
Thank you to both of you and to the folks at the Autoimmune Summit for inviting us to participate in this. And we'll turn it back to you.
Thank you.